Hi there, welcome to Doc Talk. As you remember, Doc Talk is the podcast that's put out by the Knoxville Academy of Medicine, which talks about health issues affecting all East Tennesseans in plain language. I'm Elise Denaney, former president of the Knoxville Academy of Medicine, and so glad you're here to join us as we talk about a really interesting topic called endovascular stroke therapy. We're going to get to that in a second. But first I want to introduce our guest today. He's one of those radiologists who you actually see at your bedside and face to face, which is a really new thing. He's a younger physician, and so he brings to the table all the new techniques for treating really critical diseases, which in my generation we didn't have a lot of options for. So he's almost Star Trekian in my mind. So this is Dr. Rob Hickson of Vista Radiology, and I'm so happy that you're here with us today.
Thanks for having me. It's good to be here.
So what's endovascular stroke therapy?
So endovascular means going through blood vessels. So endo through the center, vascular blood vessels. Typically, because you're treating stroke, which is an arterial problem, you're going through the arterial system. Most common access is from the femoral artery in the patient's groin, although sometimes we go through the radial artery in the wrist, sometimes we go through the brachial artery in the arm, or sometimes, very rarely, we'll even directly go through the carotid artery in the neck. And so stroke is a very complex topic. If you just look up stroke, you might get a wide variance in your definition. I think for simplicity, it's better to think of stroke as ischemic stroke. So you have a blockage in an artery in the brain that's cutting off blood flow to
Like a heart attack. When you don't get blood to the heart, you get a heart attack.
Some people call them brain attacks.
Brain attacks.
Yeah.
Okay, brain attack.
Whereas if some people consider hemorrhagic stroke, a ruptured brain aneurysm, that's technically a stroke, but it's a completely different disease.
Okay, so that's really interesting. So we've got an artery here in our groin, and we've got one in our wrist and in our elbow. And they all can actually, you can put a needle in them and you can reach the brain?
Yes, yeah. I tell people it's like working on a car through its tailpipe. And I had a patient one time say, well, don't go through my tailpipe. But yeah, we use x-rays to see where the tubes and wires that we're using are in the patient's body. Some people think that the catheters, the tubes that we use, have little cameras on them. I wish they don't. But no, we use x-rays. Yeah, eventually, yeah. But we use x-rays, live action x-rays. It's called fluoroscopy. And then because if you're just taking an x-ray, you have, the bones and soft tissues and everything, but you can't see the arteries themselves. So we inject contrast, which is the same type of contrast that you use when you're doing a CT scan. Inject that directly into the arteries, and that gives you sort of a roadmap of where you're going.
Interesting.
Yeah.
So when you get a stroke, like you said, an ischemic stroke, so that means my brain's not getting enough oxygen because the artery that feeds my brain is clogged.
Right. Yeah. Yeah. It's all kind of about plumbing, really. You have four main arteries that go to your brain, two carotid arteries that run up in your neck in the front. That's the pulse that you can feel. You also have vertebral arteries that run up in your spine that come off the arteries that go to your arms. And those two arteries join to form an artery called the basilar artery. All these arteries can be a source of a problem when you have a blockage. Most people are right-handed, and even the people that are left-handed tend to still have language dominance on the left side of their brain, so left-sided strokes affect the right side of your body. They tend to be more severe than right-sided strokes affecting the left side of your body.
So when you get this catheter that goes through the plumbing, your job is to open up the blockage.
Right, exactly. And so there are a couple ways you can do it. So the most common place to have an ischemic stroke that you can do endovascular therapy for is the middle cerebral artery, which is a branch from the carotid artery. Feeds a good portion, almost all of the flow to one half of your brain. Okay. And so you get a pretty good-sized catheter up to the clot, and the ways of doing it are sort of operator dependent. Some people like to do one thing first, some people like to do the other thing first. The way I do it is I take that catheter up to the clot, and then I hook up a vacuum suction to it and just try and suck the clot out. Awesome. And there's another way of doing it. If that doesn't work, you can use something called a stent retriever. And so a stent, I tell people, is sort of like the cardboard of a toilet paper roll, only it has a bunch of little holes in it, and it's made out of wire. And so the stents you think about, like if you're having a heart attack, place a stent to open up the coronary artery, you think about leaving the stents behind. But what's special about a stent retriever is that it's attached to a wire that then, when you open it up in the clot, you actually drag the stent out, and hopefully the clot sticks to the stent. Yeah.
Pretty cool.
Yeah, it's
like
really
a
cool.
Basket fish hook.
Kind of, yeah.
So, you know, I do nosebleeds, and
Yeah, me too.
if I, you do?
Yeah.
We'll talk about that. So if I catch a clot early enough, it sucks out just like a little piece of grape jelly.
Right, yeah.
Is that the same like in the stroke? You have to catch it early?
So yes, for lots of reasons. So most of the clots that we're dealing with in an ischemic stroke come from the heart. Most of them come from a situation called atrial fibrillation, where one of the chambers of the heart doesn't really beat properly. It just sort of quivers, and that allows it to that allows blood to sort of swirl, and then clots form whenever you have kind of stagnant blood flow. And so if the clot's really old, sometimes it can become what we call organized, and that can be a more challenging clot to get out. If it's a fresh clot, those tend to come out really easily. Now, not all strokes are able to be treated this way, right? This is about maybe about 10 to 25% of strokes just that occur throughout the nation. But these are the very severe strokes. These are strokes that, you know, if left untreated, could be fatal.
Right.
You know, sometimes patients have strokes that you can't actually see the clot based on imaging, and those, of course, are not ones that I can go after and open up. But those are good candidates for, if they get to the hospital quickly, within 4.5 hours or so, those are good candidates to get an IV drug called TPA that helps dissolve the clot. So.
Before you see them?
Before I see them, yeah. And depends on where you are, on at what point the patient gets TPA. What we tend to do is as soon as the patient hits the door in the emergency room, the emergency medicine doctor sees the patient, determines that, oh, this person is having a stroke. You can tell clinically that someone's having a stroke. So we rush them to the CT scan to make sure that the patient hasn't had any bleeding. You can't actually see a stroke on a regular CT scan right when you first do it. The changes haven't taken effect. But everyone knows the person's having a stroke. The whole idea is to make sure that they don't have any bleeding, so that then you can give the IV medication too. And we give that IV medication right in the scanner as we're getting ready to do the more complex imaging, trying to see the blood vessels themselves too.
That's great. And then that medication also helps to keep all the other pipes open.
It does, yeah, it does, and it doesn't always work on the large clots that I work on. Actually, most of the time it doesn't, because they're just such big clots. But it does. There is some evidence that it helps people down the road, because sometimes I'm not able to get the clot out all the way. Sometimes there's a little piece that breaks off and goes downstream too far for me to get, and that medication sometimes helps dissolve that too. So yeah.
That's great.
Yeah.
So now, so you get called a lot at 2 in the morning.
I do.
To rush to the hospital and to suck out a clot.
Yeah.
Now, you also have a clinic, so sometimes Uncle Joe will have had a scan, and it shows that Uncle Joe has an aneurysm.
Yeah.
And sometimes those aneurysms bust open, and that's when you have that other kind of stroke that you mentioned. But you can prevent that from happening.
That's right. Yeah, that's right. So no one knows exactly how many people out there are walking around with brain aneurysms. Most people think it's a fair amount. Depending on who you read, it's anywhere between 4 and 10% of people have a brain aneurysm. Most people don't know it. The risk of an aneurysm rupturing is related to its size. Based on a lot of studies, we know that aneurysms less than about 4 millimeters in size are really low risk of rupture. And so a lot of those people will just follow, make sure it's not growing, that kind of thing. When it gets above 4 millimeters, then I start talking to patients about, consideration of treating it. And back in the older days, the only way of treating a brain aneurysm was open brain surgery. Remove a piece of skull, kind of remove the brain over, find the aneurysm, and place a clip around the outside of the aneurysm. By the way, an aneurysm is kind of like a blister on a blood vessel.
Thank you.
Yeah, no problem.
Yeah,
because it's just like if you drove your car over a curb and sort of sidewalled your tire, the tire sort of bulges out. Yeah, and it's a weak spot. And as it gets bigger, it gets stretched more and more. And so what you really worry about brain aneurysms is them rupturing. 10 to 15% of people die immediately when a brain aneurysm ruptures. And another significant amount of people have some bad neurologic problems.
I mean, my generation, we pop a blood vessel in your head, in your brain, and we had nothing else to offer.
Right. And so now the way most aneurysms get fixed nowadays is by people like me with endovascular therapy. Most of them get treated with these little pieces of platinum wires called coils. The technology involved in making them is just kind of astounding, really. And they're size to the aneurysm.
So how big are they? They're like this big?
Well, it depends on the size, yeah. So there are some that are that big. The aneurysm coils are sized based on the diameter that they try to make when they're just sort of free. They try to make a ball, most of them anyway. And so we have a 1 millimeter coil, that's the smallest. We have a 1 millimeter by 1 centimeter coil, so the centimeter is how long it is. But that's used for treating really small aneurysms. Yeah, there are other ways of treating aneurysms too. Back in around 2012, a special stent was kind of invented and came on the market. Called a flow diverter, and it's a braided stent that you don't place anything inside the aneurysm itself. It sort of diverts the blood flow away from the aneurysm, and so you have lots of arteries in your brain that serve to actually feed the brain itself. And so if you were to cover them up with like a completely covered stent, you would cause a stroke. Right. But since this stent is braided, the arteries that you cover stay open, but it disrupts the flow going into the aneurysm enough that it causes it to clot. So it's really amazing. It's one of the I love my job. It's
I
so
can
cool.
tell.
Yeah.
It is so interesting because while you're talking, I'm envisioning this kind of scenario, and I don't mean to be like, Chicago MD or anything like that, or any television program, but you have Uncle Joe coming to the ER. He can't talk, he can't walk. You take him to the CT, take him to the OR, you appear, you open up the blood vessel, he comes out of the OR, and he's talking.
Yeah, and that's great when it happens. It doesn't. It's really so rewarding.
Yeah.
Sometimes we do the procedure and people go completely back to normal. And I absolutely love it. It's the best feeling in the world. It's almost like a Lazarus, And sometimes I just have to tell everybody, though, that it doesn't always happen that way. The vast majority of people that you treat, it's about making their stroke less bad, And so a lot of times people come to you and they would have died, but now they have some arm weakness that usually gets better with rehab.
Well, yeah, our brain, I'm sorry, I hate to keep referring back, but we believed there was no plasticity or growth of brain cells, and that's not true.
That's not true at all. No. That's not true at all.
So even if I have a weak arm, it can become stronger.
Absolutely, yeah. I tell people that all the time, that immediately after your stroke, as long as something bad doesn't happen, like you have bleeding into the damaged area, something like that, or you get pneumonia or something along that line. But people are always their worst right after their stroke happens. And you see dramatic improvements in 24 hours, a week, and 6 months down the road. I mean, I'll see people when they go to rehab after I've done a procedure, and they were not able to talk at all before. Now they can talk. They have some trouble getting words out. But then they come back and see me in 90 days and they can talk normally again, It's really
You've
amazing.
given back their life.
Yeah.
That's pretty amazing.
Pretty cool. I love my job.
All right, so, I can envision endovascular approaches to all sorts of things because we're creatures that have blood vessels that travel pretty much everywhere in the body. So the sky's the limit for your specialty as we go on, and it's known as interventional radiology.
That's right. That's right. So interventional radiology is sort of the broad, category of what I do. I'm a neurointerventional radiologist, so I did special training in neuro, so the brain and spine, that stuff, and that's actually the only type of interventional radiology that I do. I just do neuro. There are some people that do the entire body. There are a lot more people that do everything except the brain and spine.
All right, well, we're having you come back because I know I call on you at 3 in the morning when I can't stop a nosebleed and I need my friend from IR to come and stop a nosebleed. Plus the fact, talking about headaches and blood patches and all of that we need to talk about later on.
For sure.
So we'll have you back.
Okay,
but
sounds good.
In the meantime, tell us how we can get a hold of you if we need,
Sure.
to come see you.
Sure. So my clinic is 2001 Laurel Avenue, Suite N304. My office can be reached at 865-595-4100, and I'm pretty much always there. So. There are 2 of us in our practice that do neuro IR. Me, I'm Dr. Hickson, and my partner, Dr. Woodward, and we see people in consultation in clinic. We do emergencies a lot too.
Well, I don't want to abuse you or burn you out. That would be
okay.
bad. Because you're like my bones from Star Trek of this year.
Oh, yeah.
So it was so great to have you with us.
Great to be here.
And I look forward to future podcasts with you.
I would love to. Thank you so much.
You're welcome. And that's a wrap.